have a patient that is a type 1 gynecomastia. I'm just going to go through and have him please flex for me. And you can actually see where the volume is. And this is primarily what bothers him. And it's giving him puffy nipple. You can see that the volume is almost such that it is approaching a type 2. I'm going to just mark the border of the pec major. And he's got a very broad pec major, so he actually has a lot of room to maneuver. So we actually keep the nipple on the chest, because the thing that we really want to avoid is having the nipple fall off the chest. Now, in terms of treatment, our options, usually with a type 1, are we would do the inferior crescent, which is basically making the incision below the areola. This is a wonderful incision because it's extremely well hidden. I usually will end up taking a little bit of skin here just to tighten it, because we want to get as tight a skin as possible. We want to be able to pull the areola that has been stretched by the puffy nipple. With this patient, we actually had a little bit of a conversation in terms of whether or not we should continue with the inferior crescent, which is, as we mentioned, a very well hidden scar, or we could actually do a superior crescent, which would bring the nipple into a little bit better positioning. This is a great way to go, but considering the patient has somewhat darker skin and may hyperpigment and he doesn't have much hair on his chest, we've elected to go with the inferior crescent. So the goals of the surgery and the goals of any gynecomastia surgery is to create a well-defined pec, the chest fold, the nipple in its proper position, and of course getting rid of the breast tissue.